this is a really exciting talk for me to be introducing. Dr. Velleman is the Director of Policy and Communications at the Schistosoma Control Initiative and a public health policy specialist. She gained a Bachelor of Science degree in International Development from the University of East Anglia and a Master of Science in Health Policy, Planning and Financing from the London School of Hygiene and Tropical Medicine. For over a decade, her work has focused on collaboration between water, sanitation and hygiene, WASH, and health stakeholders to tackle communicable diseases and more broadly maternal and child health. Working in several countries, including Nepal, Nicaragua, and Uganda, she understood health systems research, led WaterAid's work on WASH and health, and supported WHO WASH approaches to tackle neglected tropical diseases before joining the SCI Foundation in 2018. Welcome, Yael.
Thank you so much, Joel, and it's a real honor to be here. Thank you very much for inviting me. And I have to say, I'm really disappointed not to be with you in person in Edmonton. I really have always enjoyed Canadian hospitality, but I'm also just a tiny bit relieved not to be experiencing the Canadian winter this February. So thank you so much for the honor of speaking to everybody today. So with that, I will begin. So, SCI Foundation, as Joel mentioned, technically speaking, SCI stands for the Schistosomiasis Control Initiative, and we were set up within Imperial College London back in 2002. But since about a year and a half ago, or 2 years, we have been an independent NGO. And what we do is we work hand in hand with national governments, usually ministries of health, to deliver their control programs for schistosomiasis and other NTDs. And you'll notice that I emphasize the word there because we're really there to support the programs that ministries themselves want to deliver. And our mission is to prevent and treat neglected infectious diseases, such as schistosomiasis and other diseases, but not just limited to that, through strengthening impactful and comprehensive health programs. Now, you might be thinking, why is she emphasizing SCI's mission so much? And actually, this is the starting point of what I wanted to talk to you about today. So what you'll see in front of you on the screen now is what our very, very old mission used to be back before 2009. And you'll notice that it sounds quite different to our current mission. It was about helping those who suffer from and are at risk of neglected tropical diseases in sub-Saharan Africa. So you'll see that there are some marked differences here. Help rather than support, suffering rather than improving health, and very much focusing on somewhere else that's not here, i.e. the UK, rather than really focusing on just improving health globally. And this is basically what I wanted to talk about today, because that change in our mission is not a coincidence. It's a product of just how much has changed in the global health and development overall agenda over the past decade or so, but also specifically within the neglected tropical diseases sphere. So before we get into all of that, just a very quick check-in on the neglected tropical diseases, and I'll move to using NTDs from now on. I hope that that's okay. I'm not expecting you to read the slide. It's a very small writing on purpose, but basically all you need to know is that the NTDs are a group of 20 infections. Different organizations have different size lists, but the WHO recognizes 20 of those. They affect a really huge proportion of the global population across the majority of countries globally. And we're really talking about a very broad set of reasons for these diseases, from bacterial to parasitic to viral. But what they have in common is the amount of suffering, the economic burden that they induce in the population, that they tend to happen in areas with poor access to health services, with lack of water and sanitation, and they don't usually get a lot of prioritization within health programs overall, and then within the global health and development agenda. So that's really what we'll be focusing on today. So why am I choosing, in a room of people who really have a very clear scientific focus, to talk about something as broad as the paradigm shift of global health? And I think that this is quite an important thing to do, because if we want change to happen, and I think Dr. Saleh's excellent presentation really reflected some of those changes that are necessary in global health, we really need to understand what has happened before and how change happens in order to be able to affect that change. And hopefully I'll be able to explain more specifically what I mean by that. So the first thing to say is that the global health landscape changes all the time, changes constantly. And I've, in this slide, only gone back to 1978, which quite handily is the length of time I've been alive. So I'm only talking about what I've experienced in my lifetime. And on the left-hand side, you'll see I'm starting from 1978, from the Alma-Ata Declaration. This was really the period of time where primary healthcare was king or queen, where health for all was becoming a human right, acknowledged by everybody. So really a good time for public health. That slightly changed, or quite drastically changed, over the 80s and 90s, when we saw really a very concrete influence of the neoliberal development agenda in social services at large, and health as well. And what we saw was really a decimation of the public health services sector. And although the title of the World Bank World Development Report that I'm showing there is from 2004, it's emblematic of the kind of trends that we saw in global health then. So very much health services needing to work as a business, and not really something that government should be spending on, because that hampers controlling inflation and public spending. Things changed quite a lot in 2000 with the Millennium Development Goals, and then again in 2015 with the advent of the Sustainable Development Goals. And this is really where I'll be focusing the majority of this talk, so the last decade or so. And I will be starting from, as I said, about 10 years ago, or let's say 2010. And I'll start with global health, and then I'll touch on what happened at NTDs at the same time. So about a decade ago, we're still in the Millennium Development Goals era. Now, for those of you who are old enough to remember, really focused on eliminating or eradicating poverty. They focused mainly at low-income countries or poor countries, not so much on the global north. And they were very much about choices, about making priorities. So if we're talking about poverty, we're really focusing on the people who are just below the poverty line. And if we're talking about health, what we really care about in order to be able to make the biggest impact with few resources is child health, maternal health, and AIDS, tuberculosis, and malaria, and other diseases. We'll come back to that in a second. The result of that in global health, and Dr. Saleh also touched on that point in his talk. What we saw in that era was really the beginning of a lot of the vertical funds that still exist to an extent and still influence the global health agenda quite a lot. So the Gavi Alliance for Vaccine and Immunization, really seen as the major intervention for tackling child mortality. Global Fund on AIDS, TB and Malaria, and some other large initiative, including the US President's Emergency Plan for AIDS Relief, which actually dates back to George W. Bush's era, but really came into its own towards the end of that decade. Who was really influential in global health at a time? And really what we saw in that era was a very central role, not just for the big global health and development institutions. So you can see on the right-hand side, Dr. Margaret Chan, who was then the Director General of the World Health Organization, World Bank President Jim Kim, and on the left, Bill Gates. And really that signifies just how important a role donors and philanthropy were playing and are still playing these days. And in fact, during that decade, Bill Gates gave 2 keynote addresses at the World Health Assembly, which is an honor usually reserved for heads of state. So that really tells us where the agenda was going. Bit of a side note, because I am conscious that this is a Canadian conference, a little bit of a rest in peace corner at the bottom of the slide for the bilateral aid agencies that existed at the time and are no longer with us. And those really were quite influential in directing the global health agenda. So we're talking about Canadian CEDA, Australian Aid, or AusAid, or what we call it today, WasAid, and DFID, who we sadly lost last year. So what did this mean for neglected tropical diseases? Now, I'm talking about NTDs as if this term always existed. Truth is that it didn't, and although it dates back in terms of a term that was thrown about quite a lot since the 1960s, it became a thing, as in a dedicated advocacy agenda, a dedicated World Health Organization department, and so on, only around 2010. So we talked about AIDS, TB, and malaria. These are really the behemoth of global health funding, as again Dr. Sala mentioned in his talk. And that really created a bit of a conundrum for neglected tropical diseases, because we're talking about a lot of very separate, very siloed areas of work, like leprosy, like schistosomiasis, like elephantiasis, and really trying to get resources on their own didn't work very well. And this is where we saw, I guess, a little bit of, you could look at it through the lens of the old Greek parable on the old man and his sons, who used to argue a lot amongst each other, and then one day on his deathbed he brought them together and gave them a bundle of sticks and said, try to break this, and they tried and they couldn't. And then when he pulled out each individual stick, they were easy to break. And so this is sort of what happened with NTDs through various people's initiatives, by bringing them together. Those very disparate communities were able to basically formulate one advocacy and lobbying front for getting the resources and attention that those other diseases from MDG 6 can really be addressed through. So what did the policy environment look like for NTDs at the time? And really the main publication that set the scene, and this is in 2012, was the first WHO roadmap for NTDs. And this roadmap was the first time that all of the different diseases were put in one document and received for each disease control, elimination, or eradication targets up to 2020. Now, this was quite important for NTDs as a term or as a community, but there were some consequences, mostly unintended. So the first one, predictably, is that although all these diseases were gathered under one roadmap, in actual fact, what we ended up having was, instead of lots of separate silos, lots of silos together. So we're still seeing, for the individual programs, quite vertical approaches for disease control, elimination, and eradication. And some of these silos weren't even disease specific, they were quite programmatic. So for example, looking at lymphatic filariasis, which is a vector-borne disease, you had one program focusing on mass drug administration using donated tablets, basically provided free of charge to populations with high levels of prevalence. And then another program altogether looking at addressing the morbidity aspects of lymphatic filariasis, like limb care and surgery. And then a completely different aspect of the program in terms of vector control being handled by somebody else. So silos were really a big issue. It wasn't the only issue. And what you can see in front of you now is the main strategies that formed this roadmap. So as you can see, we've got preventive chemotherapy, which is what I just mentioned, mass drug administration using donated drugs from pharmaceutical companies managed through the World Health Organization. We had case detection and management, veterinary public health, vector control, WASH. So you might be thinking, great, this is a very comprehensive approach, but in actual fact, given the fact that most of the resources and most of the momentum, especially from 2012, was generated through the donation program, what really took precedence in the implementation of the roadmap was mass drug administration. And it's still a really important part of what SCI Foundation does, or the lion's share of what we do. This, of course, means that doing things like working across sectors becomes very difficult because the incentives for collaborating aren't really there. If we've got, and this is something that is quite important within the roadmap, if we're measuring process mainly rather than impact around what percentage of the population are we able to cover with mass drug administration, and we've got very vertical programs, and the funding that's channeled to NTD programs is also quite vertical, there isn't really an incentive for the doctors and engineers to work together. So although the link with other sectors was acknowledged, it wasn't really strongly operationalized. I'm going to pause talking in a moment and show you a little video. And this is something that's important because although the policy is really what drives how the sector operates programmatically, there's also the issue of the narrative that accompanies it. And that also relates a little bit to some of the aspects that Dr. Saleh covered earlier. So I'm going to show you a video, and while you watch it, I'd like you to reflect, and if you want to also put into the chat what you think about what's being portrayed to you. So what's the image of the people who are affected by the issues covered in the video? What do you see about where they live? What are the power dynamics that are being shown here? Whose voice is being heard? And what's the message that you're hearing from this video? I really hope this is going to work.
sure you want to see the end of this as much as I do.
The great news is that we can.
All it takes is a simple packet of pills.
All it costs is 50 cents.
To treat and protect a child for a whole year
against all 7 of these diseases.
What's even more amazing is that if we all join in, we can see the end of all of them by 2020.
Join in and be part of something huge by liking N7 on Facebook, making a small donation and spreading the word by telling all your friends.
Together,
we
can see the end.
Great, so hopefully you'll have seen this, and unfortunately I can't see the chat, but we'll come back to that later. But so as you can see, that video was from 2013. It was quite emblematic of how this issue of NTDs was being portrayed at the time, and hopefully it is a little bit jarring to you because it's probably not something that we'll be doing these days, almost 10 years later. So in terms of the image that at least I think was being portrayed, we're really seeing people who are other to us, who live somewhere, not here, a poor place, Africa at large, not really a specific country, and you're probably feeling quite sorry for the people that you're seeing. So there's something here about victimhood, about voicelessness and powerlessness. The power dynamics are quite clear. The power is in your hand as the viewer, not necessarily the people that you're seeing or the people who work in those communities. They're all voiceless. We don't hear them. We hear the celebrities who are predominantly white and high class. And the message is really quite simplistic, isn't it? So the solution is just this tablet. It only costs this much. And it really doesn't get into the details of the real cost of program implementation at a country level and the capacity that exists within ministries of health and local health programs to deliver those programs. So hopefully we'll have come a bit of a way since then. So things have moved on a little bit, and in this next section I'll talk about what I think drove those changes. And of course I'm generalizing quite a lot, so please forgive me, but that's the time that we have today. So first of all, we talked about the Sustainable Development Goals, and actually, although these were published in 2015, they started emerging in late 2013, 2014, when there was a realization that the MDGs are about to expire, and we really need to rethink what global development needs to look like. And the main difference between the SDGs and the MDGs were the fact that they were universal. They are universal. They discuss all countries everywhere and poverty wherever it may exist. And equity and leaving no one behind are really the main tenets of the SDGs. And within that, instead of focusing on reducing child mortality or tackling specific diseases, the health-related SDG is about good health and well-being. It's about the ultimate outcome that we're all trying to reach. Those trends in themselves are actually a maturation of processes that started happening actually around 2005. The aid effectiveness debate, some of you may be aware of the Paris aid effectiveness agenda, which then turned into the Busan agenda. And really what that involved is the relationship between powerful countries or high-income countries and donors and the countries that they are trying to help. And so the aid effectiveness agenda really put into concrete action the harmonization between donors. So instead of asking ministries of finance to report separately to each donor, trying to really create comprehensive funding mechanisms that are much easier to manage. alignment with national development plans and within that health plans as well, and ownership. So really the people who are leading the change process for global health and development should be countries themselves. And the International Health Partnership, which was created around the same time, was really a translation of that aid effectiveness agenda into the global health agenda, but trying to implement exactly those steps. Now, in neglected tropical diseases, we have a bit of a mixed picture. And there was a lot of progress that was made, and I'll talk about that, but also some challenges that are really driving the changes that we're seeing in that particular community. So this slide was actually only just presented last week by Dr. Mwele Malechela, who you can see on the bottom left-hand side of the screen, who is the Director of Neglected Tropical Diseases at the World Health Organization. And I'm proud to say she's also an observer to the board for SCI Foundation. And as you can see, a huge amount has been achieved. So 42 countries eliminating at least one NTD, pretty incredible. Huge reduction in specific diseases like sleeping sickness or human African trypanosomiasis, 300 million fewer people needing the treatment that we talk about, those mass drug administration programs, and really huge amounts of treatments being donated through what is actually the largest public-private partnership globally through the drug donation program. So really fantastic achievements overall. However, and you were expecting me to come up with some challenges, there are some pretty major ones that we're still dealing with now. So I mentioned earlier that the roadmap, the 2012 roadmap, had some eradication targets, and actually 2 diseases were scheduled for eradication. And by eradication, we mean the organism actually not existing anymore globally, maybe just in a lab, just like smallpox. And those diseases were guinea worm and yaws. Now, yaws wasn't eradicated by the deadline of 2020, but importantly, guinea worm was not eradicated by 2015, which was the original timeframe. Now, we do have very few human cases. They're under 100 each year. But what we didn't anticipate was the unexpected animal reservoir with canine guinea worm being capable of infecting people. And that picture only emerged as human transmission was reducing significantly. So those goals have not been met. Now, I mentioned earlier that a big part of the previous roadmap was the issue of coverage. So making sure that we have at least 75% of the population covered by those treatments delivered through mass drug administration. But what does coverage actually achieve? And this is just one example from the soil transmitted helminth program in Kenya. Thank you very much to the Ministry of Health in Kenya for this data. And what you can see in front of you, I hope it's not too difficult to read, is a massive reduction in the prevalence of the parasite, and in this particular case, Ascaris or roundworm. You saw a picture of that in the video. And then within 6 months to a year, basically going back to the same level of prevalence. And that is because treatment doesn't prevent reinfection from happening. And in the absence of dealing with the environmental and behavioral causes of parasitic disease transmission, the effect of mass drug administration can't always be sustained. And then finally, we have this quite difficult issue of elimination as a public health problem. And this is a very specifically defined term, and several of the NTDs have a target for elimination as a public health problem. What does that mean? It means bringing the prevalence of the disease below a very low percentage in the population, but it's not completely gone. And I'm using the example of leprosy here because actually, globally, elimination of leprosy as a public health problem has been achieved in the year 2000. And it's defined as less than 1 case per 10,000 population. However, we look at the data from the Lancet from 2018, we can see that there are still 500,000 existing cases of leprosy globally, and over 200,000 new cases emerging. So although it still meets that criteria of under 1 case per 10,000 population, it's by no means gone. And the problem is, and I'll come to that in the next slide, that means that we've actually got a mismatch between what we think has happened and what's still happening on the ground. And to quote my old professor from London School of Hygiene and Tropical Medicine, Paul Fine, he said in 2007 that neither funders nor young researchers are attracted to an officially eliminated disease. So borrowing from another eminent professor, this time Professor Christopher Whitty, who is currently the Chief Medical Officer of the UK. So he's become a bit of a celebrity over here. We see him a lot on TV because of COVID. But he really talks about the challenge of elimination and eradication, as you can see in the slide, in terms of the fact that where it gets harder, it's much harder to get the kind of political support that you need. And as you can see from this slide, the major gains in disease control are usually made when there's a lot of it. So, for example, if I wanted to lose a lot of weight and I was quite heavy, and this is something I've experienced before, it's always easier to lose those first 10 kilograms, and it's the last kilo and 2 kilos in the end that are hardest to lose. Why is that in NTDs? Because when we're talking about elimination and eradication, those few people who remain in the end are actually far away, hard to reach, don't usually have services, and therefore are more expensive to reach. But by that time, that problem is no longer a big public health problem. And this produces what Professor Whitty calls a political paradox over time, because actually eradication is most popular politically and financially and with donors when it's least achievable, when it's a really, really big problem. But in the end, nobody cares anymore. And I'll give you the example of trachoma in Colombia. Those of you who are not familiar with trachoma, it's a bacterial infection that causes blindness by causing scarring underneath the eyelid, and the eyelashes turn inwards and scratch the cornea and cause a lot of pain and disability and finally blindness. Now in Colombia, they still have trachoma. It's very focused in the Amazonian region. It's extremely expensive to reach patients with the final stages of the disease, $400 per person, which is a huge cost in public health. But Colombia, no longer being a low-income country and no longer having a very big burden of the disease, doesn't have any external development partners who support their program, and also their own Ministry of Health won't put resources into it. So the problem has not gone away, even though trachoma globally is reaching, is starting to reach elimination as a public health problem. So, of course, none of this was lost on the NTD community, so things did begin to change. So around 2014, and actually published finally in 2015, we saw a lot of momentum starting to happen around collaboration with the WASH sector. And really there was an acknowledgement that if we're going to achieve the targets, and especially the SDG targets that are really the high level ones around health and shared prosperity and equity everywhere for everybody, we've got to work together. And we need to find a concrete agenda to coalesce around. And the World Health Organization published its first global strategy on water sanitation and hygiene for NTDs. And the people you can see on the right-hand side are the Director for NTD Control at the time, Dirk Engels, and the Director for Public Health and the Environment, Dr. Maria Nera, signing their autographs on this really crucial strategy. And then secondly, and this is something that came out of the NGO community actually, that's working on NTDs, the NTD NGO network, or the NNN, which is a meta acronym, my favorite kind of acronym. And that community came up with another way of branding the breadth of interventions that are needed for tackling NTDs by calling it the BEST framework, and saying that actually, if you want to get rid of NTDs forever, you have to tackle all of these components at the same time. You've got to look at behaviors, not just individual ones, but also institutional ones. You've got to look at environmental factors, including animals, really crucial, especially these days. You've got to look at social inclusion and make sure you're leaving no one behind within your programs. And also, of course, you've got to ensure there's treatment and care, and that's being made available to everybody everywhere. So where are we now? And hopefully, you know, this is where the good news stories start emerging. So in global health, and this won't be a surprise to any of you, I'm sure, we're really in an era where universal health coverage is getting its comeuppance. It's being recognised as really the most important framework for approaching healthcare services. And we're talking about everyone, everywhere having access to quality services and ones that are also acceptable to them culturally. And are accessible to everybody, and without the risk of financial hardship. So this is really a crucial part of universal health coverage. So we're almost, I guess you could say, kind of going back to 1978 and the Alma-Ata Declaration. Within that, if UHC is the how of achieving SDG 3, then health system strengthening is the how for achieving universal health coverage. So in any work that's being done to support a country anywhere, this should be done to strengthen the existing health system. Now, this is a really important shift because what I didn't mention earlier on about the vertical funds is that those actually created quite a big problem in a lot of low-income countries in undermining primary healthcare. What do I mean by that? There were some quite absurd situations where you can see a very well-funded HIV/AIDS clinic right next door to a really underfunded, dilapidated primary healthcare clinic with no staff, because they've all gone to work for the really well-paid vertical disease control program. So we're trying to reverse that trend now through the UHC lens. UHC 2030 is the next iteration of the International Health Partnership, which I mentioned earlier on. They've rebranded, and rather than being a donor versus countries partnership, it's now a partnership of all health stakeholders. And because it's my favorite pet issue within global health, we have seen a real buy-in towards the WASH and health movement more firmly, not just as another sector that health needs to work with, but actually as a responsibility of the health sector. And we saw the first publication of the global report on WASH in healthcare facilities. And there have been more reports since then. In NTDs, things are really looking up, and just a week ago on the 28th of January, the World Health Organization published its new global roadmap for for NTDs. Old habits die hard. And this roadmap takes us through to 2030, so it's aligned with the SDGs. You can see its main pillars: accelerate programmatic action, intensify cross-cutting approaches. So that intersectoral aspect is now one of the three pillars, and changing operating models and culture to facilitate country ownership. And I've got a picture here of Dr. Mwele Malecela from the World Health Organization again, because I think that it's quite important to acknowledge that this is the first time, and she joined 3 years ago, I think, that we've got a director for neglected tropical diseases in Geneva, in WHO headquarters, who herself was a national program manager for NTDs, rather than someone from a high-income country who has not had that experience on the ground. Now, I mentioned earlier the three main policy aspects of the previous roadmap: measuring progress, process, vertical programming, and partner support and funding. And WHO has really put three key shifts at its current approach to NTDs within this new roadmap. So instead of measuring process, we now measure impact, and impact includes actually having specific targets for access to water, sanitation and hygiene in endemic areas. From vertical programming to holistic cross-cutting approaches, and from a donor-driven agenda to really putting country ownership and domestic resource mobilization at the heart of NTD programs. So this is all great, but where are we now, and are we really on track? Can we just say we've reached the pinnacle of all of these changes? Well, not quite, I'm sorry to say, although these are really positive trends. So in these last kind of 2 slides, I'll try and project to you what I think needs to happen and why I think we have a really unique opportunity now to make sure that this trend continues to stay positive. So in both global health and NTDs, we're not quite there yet in terms of the shifts that are needed. Now, you still hear the language of disease control, whereas what we're trying to achieve, if you think back to SDG 3, is improving health and well-being and putting people and their well-being, financial, health, mental and otherwise, at the heart of all our efforts. Now, with COVID-19, again, we're seeing these kind of approaches playing out where we're trying to control a disease and preventing it from spreading without really addressing the very deeply embedded social inequalities that define what outcomes that disease is going to cause. So that's really one important shift that needs to happen. Now, we say that what we're doing is in support of countries, but I'd say we need to take that a step further. And if we're really serious about decolonizing development and decolonizing global health, we need to take it a step further, where really all we're doing is making sure that programs are being rolled out and reducing the amount that those programs depend on external support. And a lot of change is still needed in the fundraising narrative and in the funding models that underpin those shifts. So although the situation has changed from the video that I showed you earlier, and we are using positive images and we're making sure that the voices of people who are affected by disease and are working in those communities are being heard, there's still a bit of a lag and still a bit of the use of the language of suffering when it comes to talking about NTDs. And the funding models, as you can imagine, take a bit longer to change. And whilst donors are more accountable these days to the countries that they're trying to support, they're still often more accountable to their taxpayers at home. And that creates difficulty in making sure that resources can just be handed over where needed, or supporting funding mechanisms to mature at a country level to enable funds to flow correctly. So that brings me to my last slide, and this is where we're talking about what's actually next, because if we say that the global health agenda is always changing, it's changing now. And I think that we're in a bit of a crossroads, and we have a choice to make, we as a global health community, but also within NTDs and also for SCI Foundation as a stakeholder within that community. We have an opportunity to ride that wave that started last summer with the need to decolonize everything we do in development and translate that into a much more positive approach to strengthening health systems, building a local capacity, and actively challenging the narratives that continue the colonization of health. And that includes our fundraising, and it also includes our programmatic action. But there's also a threat. And to me, COVID-19 is not just a threat because of the very pragmatic aspects that we are experiencing, but also because I feel that it's already creating a reversal in trends. I'm not sure how far back, but it is creating a much stronger language of protectionism, of global health security as a self-serving agenda. So we need to protect our borders from diseases, and therefore that's the main reason that we spend on global health, not because we want to achieve health and well-being for all. And the type of funding that generates and the type of programs that generates takes us back to vertical approaches and very much an externally driven agenda, rather than trying to address the really systematic issues that underpin global health. So we've got a way to go. And I do hope that we're not going to see a complete reversal in trends, and that we'll be able to take this opportunity. And certainly from the SCI Foundation perspective, we're hoping that the only way is up. So I'll stop there. I think that's my time. And just by coincidence, we've even got the Canadian flag on this last slide. I promise it's a total coincidence. So I'll hand back to Joel, and I'm happy to take any questions.